Okay, good morning, good afternoon, good evening. This is Dr. Garais, BIO116, and this is a quick summary video on chapter 20. Okay, chapter 20, of course, is renal. And the renal system is comprised of the kidneys, ureters, urinary bladder, and urethra in that order. The kidneys are the star. Everything else is a delivery system to get urine out of the body. Other functions of the kidney, other than filtering the blood and urine, is that it also maintains the composition of what's in the urine. So we already talked about how waste, everything that's extra that the body does not need, it's considered waste. And the maintenance of this composition of what's in the urine helps mitigate that, and that's homeostasis. pH as well, because if I start dumping out H pluses, if I'm acidic, I can make my pH closer to 7.3 to 7.4, which is physiologic pH. And of course, urine is made up of water as well, so I can also, or the kidneys can also control body fluids. Okay. Another thing is there's certain things, all these substances that, like drugs and also toxic metabolites, also get released in the urine. And we use this fact in pharmacology to either maintain drug volumes in your body or to reduce them. Because if I chemically tell my kidneys to get rid of something that's water soluble, then if a drug is water soluble and I make it pee more, then I can get rid of it that way. And we can also do the same thing regarding pH. We mess with the pH to either acidify urine or make it more alkalized urine to play around with the chemistry. And last but not least, we're going to talk about the renin, angiotensin, aldosterone system, which are the main hormones that regulate the above that we just talked about. So here are your kidneys, your ureters, you have two of them, and then your bladder, and then your urethra, which connects your urinary bladder to the outside world, to the toilet. You'll notice that your right kidney is a little bit lower than your left, and it's because your liver is here pushing down on that. The location of your kidneys are located behind the peritoneum, therefore it's retroperitoneal. So any issues with the peritoneum, in theory, should not affect the kidneys. Your kidney is surrounded by a renal capsule made of a lot of fibers. It has a ton of renal fat and also connective tissue, not only to keep it in place, but again, by protective function. So you can see how important your kidneys are due to its location in the posterior abdominal wall, behind the retroperitoneum, and then you have three things here to shroud or protect your kidneys: renal fascia, renal capsule, and adipose tissue, also known as renal fat. Now, the cortex and medulla and all of these things are part of your kidneys, and it's better to look at this picture. All around the area here, your kidneys are this is your cortical area or your cortex. It's all on the outside. Now, your medullary area is all the funnels here on the inside. So the filtration part here, that is called your cortex, and it contains something like 350 million microscopic functional units. And this unit right here is called your nephron. So nephron located in the cortex. The cortex is highly vascular. And then you have all these funnels, that's your medullary area. And the funnels go in this order: renal pyramid, minor calyx, major calyx, and this area right here is your renal pelvis. And then it connects into your ureter here. Renal artery and renal vein. The renal artery brings in dirty blood, which has a lot of nitrogenous waste, and it gets filtered here in the nephron. We're going to talk about the nephron momentarily. You can also see the blood supply is significant, and it is one of the first tributaries that comes off of your abdominal aorta. So This is highly vascularized and highly important, and that's why you have two of them. You'll also notice the structures holding up the renal pyramids. It's right here, and that is your renal column. Okay, the area right here is called the hilum, just like the hilum in your lungs. It contains the renal artery, colored red, renal vein, and of course your ureter. And that is actually where all the hilum right here is where all these funnels converge into the renal pelvis, into the three, and these are the three main tubes of your hilum: renal artery, renal vein, and of course your ureter. You can see here that the major blood supply from the abdominal aorta goes in here, and of course your inferior vena cava, the venous blood goes back up. We already know that from our cardiovascular. Erythropoietin, we already talked about, is the important hormone, along with the liver, that gets secreted when there is low blood oxygen carrying capacity. Let's talk about renin, angiotensin, aldosterone later, but just know that renin, angiotensin, and aldosterone help to increase blood pressure, and we're going to talk about the details momentarily. Another thing that kidneys also do, they produce the active form of vitamin D, also known as calcitriol, and we know that vitamin D is part of the calcium balance. This calcitriol, also known as vitamin D, increases calcium absorption from the small intestine. So when your blood calcium is low, your kidneys secrete vitamin D, and then it tells your small intestine, hey, from the diet, make sure to take in more calcium. Hemodialysis and continual peritoneal dialysis. No, it's nice to know, but we'll go over that in lecture. Again, we're focusing on anatomy and physiology. Afferent, efferent, arterioles and glomerulus and all this stuff is best talked about through this. This is your nephron. And oh, there's about 1 million of them. I thought like 300 million. No, maybe it's 350,000 or 500,000. I don't know. But there's 1 million of them, and they're microscopic. And what do they look like? Well, let's look at this. So the first thing it does, this is an afferent arteriole. All right. Efferent means exiting. Afferent, we're going into. So the afferent arteriole, once the renal artery, it breaks down into different arteries, and the arteries get smaller and smaller until you get to the afferent arteriole. And this is this glomerulus, not glomerulus, this nephron, this whole thing. The majority of it is in the cortical or cortex region or outer region of your kidney, and it's microscopic. So what happens? Dirty blood goes in through here. The glomerulus, which is this tuft of capillaries, filters it. It filters it into this capsule right here called the Bowman's capsule. This glomerular capsule is called Bowman's capsule with a capital B, B-O-W-M-A-N, Bowman. Then it goes into the proximal convoluted tubule. Then it goes into the loop of Henle here, which has a descending limb, and you can see a thin part. And then an ascending limb has a thin part and then a thick part. And since we have a proximal convoluted tubule, you have also the distal convoluted tubule. So that's the order it goes in. And what are the functions? Well, the function of the glomerulus is for pure filtration. There are two backup functions that are in the proximal convoluted tubule and the distal convoluted tubule. The two backup functions to this glomerulus is called secretion and absorption. Secretion is when we didn't throw out something that we should have thrown out. So that happens in the proximal convoluted tubule and the distal convoluted tubule, and that's called secretion. Reabsorption is I threw out something by accident and I want to take it back in, and that too happens in the proximal tubule and distal tubule. Now the function of the loop of Henle in the descending limb it only is permeable to water. And then in the ascending limb, it's only permeable to sodium and chloride ions. And the function is this, it creates what they call the countercurrent, which helps concentrate your urine. And then last but not least, there's a collecting duct that they removed here. Maybe we'll look at the collecting duct. Here you go. And that's in the end. And the collecting duct, let's pan back a little bit. The collecting duct, as you see here, forms all these little strands that are inside the renal pyramid, which is the first funnel that you'll see in the medullary area. Okay. Now, if we look at this, all these fenestrations, it looks like a car's oil filter to me, right? And that's exactly what it does. And this is called the glomerulus. It's a tuft of capillaries, and you can see here, very thin walled, and that's where the filtration process. But because the glomerulus, or this filtration system, isn't 100%, it's about 80% or so, things get messed up, and that's what we talked about in the proximal and distal convoluted tubules. Here's the proximal, here's the distal. That is where secretion and absorption happen. And here's a nice little thing that you really should not memorize. Another thing is the JG apparatus, or the juxtaglomerular apparatus. Its function is to monitor water balance and urine concentration. And indirectly, it actually is a monitor, since it does water balance and what kind of salts are in urine. It monitors blood pressure, and that's what the JG apparatus is for. And you can see it here. See, juxtaglomerular apparatus, and it monitors blood pressure. And the macula densa monitors sodium chloride. And you can see here, the macula densa part of the JG monitors sodium chloride, and it makes sense. And the juxtaglomerulus means if you're juxtaposed to something, you're glued right next to it. So the glomerulus is right here, and the JG apparatus is here, monitoring. The macula densa monitors salt and chloride, but the JG apparatus as a whole monitors blood pressure. So, and this is what we talked about earlier. Filtration, reabsorption, secretion. Filtration happens in the glomerulus. Reabsorption and secretion happens in both the proximal and distal convoluted tubules of your nephron. Fenestrae, those are the tiny openings, or those little filter-like things in the glomerulus. That's these little things, these little slits right here. Okay. GFR. Now, you don't need to memorize this stuff, but GFR is what we monitor. It's called the glomerular filtration rate. This is how we know that your kidneys are working. And we have different tests to do that. Your creatinine test and your inulin test monitor GFR. And it does a pretty accurate job on how well your kidneys work. So GFR, your glomerular filtration rate, is the measurement of the efficiency of your kidneys. This is a simplified version of the renin-angiotensin-aldosterone system. Let us now do an RAA. Minute. Do the renin-angiotensin-aldosterone system, and my most favorite drawing or diagram, if I can find it. I really should save it. Every turn I'm looking for it. Here it is, and it's on YouTube. And let's see. I can copy this image and then put it on here so we can look at it. So let's bring it over here and let's look at this. So this is the renin-angiotensin-aldosterone system. And remember, when we're looking at a homeostatic system, which is this, or a thing that's going to control our blood pressure and our um, 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 fluids. So we got to start off what activates the RAA. So we can look at these three boxes first. And remember, you combine things so you can get to learn things. So when you look at this, there's three sets. One you have here, two you have here, then you have the end part, which is this part. And there's two things in the end part. One deals with what? Increased blood volume. The other one deals with the vasoconstriction of arterioles. Because the ultimate thing we want to do is increase blood volume, increase blood pressure. So that means we start off, or the impetus is what? Decrease blood volume and decrease blood pressure. So where do we get that? We get that in dehydration, if you have a sodium deficiency, or if you're bleeding out. Of course, you're going to have, if any of these things happen to you, or a combination of these things happen to you, you'll have decreased blood volume. And if you have decreased blood volume, you have decreased blood pressure. Now let's look at the second part. The second part, I kind of look at it as the organ parts. The decrease in blood pressure, your JG cells that are inside your kidneys are going to detect it. Then your kidney is going to release renin. It goes, angiotensinogen is floating around from your liver. Angiotensinogen, you could see ogen means it's a precursor. It's inactive. It gets activated by renin, and renin now makes angiotensin 1 from angiotensinogen. Angiotensin 1 then gets converted to angiotensin 2 because of ACE, angiotensin converting enzyme, and those are found in your lungs. Now, when angiotensin 2 increases, because you're going to have two responses. You're going to have vasoconstriction of our arterioles and increased blood volume. How do you get vasoconstriction? Well, you have your adrenal cortex here, right? And well, let's talk about vasoconstriction first. Look at the word angiotensin. Angio means blood vessel, tensin means to what? To tense, or to squeeze. So vasoconstriction of our arterioles caused by angiotensin 2, you're going to have, of course, what? Increased blood pressure. Now, what's the second thing that happens in this box, or this area right here? Your adrenal cortex, look, has an A, right? A, increased aldosterone, because this is the renin, angiotensin, aldosterone system. So what's going to happen? Because your increased aldosterone is going to now increase blood volume. And how does it do it? Increases sodium. And remember, wherever salt goes, water goes. So if my kidneys retain sodium, you're going to have what? Water reabsorption. Increased water reabsorption, you're going to have increased blood volume, and therefore increased blood pressure as well. And you'll see here, what are we going to kick out in return? If I'm getting in the, remember a loop of Henle I just showed you? If you take in sodium, you have to kick out potassium and H+, because we have to have a balance of pluses and minuses. So this is also a way I can kick out potassium if I mess with my sodium, or I increase sodium and water reabsorption, and I could also do what? I could also kick out H+. So the RAA system also deals with what? pH. So if you look at this, I could ask you, what is the impetus? Decreased blood volume, decreased blood pressure. Impetus, or the starting point, from dehydration, sodium deficiency, and hemorrhage. What's the end point? What's our goal when we activate RAA system? Two things. I want the blood volume to go up. I want the blood pressure to go up. And it's two things that does it: vasoconstriction and increased blood volume. I could ask about JG cells. What do they monitor? Blood pressure. Blood pressure drops. Who gets increased? Renin. Where's renin from? It's from the kidneys. Angiotensinogen. Where's that from? Liver. Angiotensinogen then converts to angiotensin 1 because of renin. Angiotensin 1 then converts to angiotensin 2 because of your lungs. And your lungs have ACE, angiotensin converting enzyme in it. So it converts 1 to 2. And then once angiotensin 2 kicks in, two things are going to happen: vasoconstriction of our arterioles and increased blood volume. Now, how do we increase the blood volume? Signals from angiotensin 2 to adrenal cortex release aldosterone. Aldosterone then has increased sodium and water reabsorption. And the side note is it also kicks out or secretes potassium and hydrogen ion. All right, it's a little bit complex. Pause this part because a lot of nice questions can come from this. And let's go back to our regularly scheduled program. So you can see how this is a simpler version of it, but the other one is a better version, more exact. Diffusion and osmosis, this is how things move around the tubes. And they're moving around from an area of high concentration to an area of low concentration. And that means it's passive transport, therefore it does not require ATP. This is another view of glomerular filtration and tubular reabsorption and tubular secretion, which both occur at the proximal convoluted tubule and the distal convoluted tubule. Now, remember we talked about if I'm keeping sodium, I got to kick out potassium. Because guess what? What's in my loop of Henle? Sodium, potassium pumps. So whenever I take in sodium, I have to kick out potassium. If I take in potassium, I got to kick out sodium. And that is an active transport. It requires ATP. It requires energy. Okay? And it is what? If it is sodium, potassium, ATPase pump, therefore it is now not from high to low, it is what? From low to high. Reabsorption, chloride, bicarbonate, again, the bicarbonate also, just like kicking out H pluses, deals with pH control or pH homeostasis. There's another way to look at it. Pause if you need. Tubular secretions, we already mentioned, sodium and potassium exchange from each other, and H plus, of course, pH. Now, let's look at renin, angiotensin, aldosterone. We already know that deals with blood pressure and blood volume. You also have cardiac natriuretic peptides. When you see the word natriuresis or natriuretic, you're going to think what? Sodium. So if I ask about cardionatriuretic peptide, it is part of the regulation of your blood pressure, specifically in sodium absorption. The concentration of urine, we talked about that loop of Henle. So the loop of Henle, another thing is also another hormone called ADH, which we already know from last term, which is prevents you from urinating. So it's going to keep the water. Now, to talk about the countercurrent multiplier, which is your loop of Henle. So when you look at your loop of Henle here, right? The first part of the loop of Henle is only it's only good for water. So this part, the first part, water goes inside. It's only permeable for water. So what happens? We know that blood, when we filter out blood, it's isotonic. So when it comes out of the glomerulus right here, the beginning of this urine is isotonic. Now, what happens if I take out the water? It's forever to use to write with the mouth. So that's isotonic. So what happens? Water goes out, and what do I now make at the bottom of this loop? Now, I take out the water, I make it highly concentrated, so that's what? A hypertonic solution. Now, what happens with the ascending loop? Now, the ascending loop, that has the sodium, potassium, ATPase pumps, but the only thing that's permeable to the ascending loop is two things. sodium, and chloride. So what is the function of this countercurrent multiplier? The function of this is to, let me go back to, the function of all of this is to what? This is where your, for lack of a better term, where your kidney decides what is um, um, what is the concentration of urine. So it can either take a whole bunch of water in, right, because of antidiuretic hormone, and then it'll be super concentrated urine, right? It goes, or take the water out to make super concentrated urine, or I don't take a lot of water or sodium out, and I can dilute the urine. So that's the function of this. And one last thing that we have to add is, if this is isotonic and the bottom is hypertonic, and then what kind of urine should I have when it's coming out of the distal convoluted tubule? It should now be what? Hypotonic. So meaning to say, there shouldn't be a lot of stuff in urine, because in theory, you're supposed to have a, in theory, you're supposed to have not a lot of stuff in your urine, only just extra stuff. So you have a hypotonic solution that's going into the collecting duct. And if you can see here, if I need more water, I could still get it from the collecting duct as well. So if I have ADH levels, right, antidiuretic hormone, what happens to the permeability of water? It increases, right? And who helps control all of that? Your loop of Henle, which is this thing right here. Descending loop, ascending. Descending is permeable to water, ascending is permeable to sodium and chloride. And the urine starts off as isotonic, when it moves down here, it becomes hypertonic, and then when it moves back up, it becomes hypotonic. That's all the stuff that I talked about here. And it creates a countercurrent, as you can see here. This is a rather neater picture of what I just drew. What's going on? Having a hard time controlling my mouth. Okay. Just another view of that. Now, what are we doing? Because I want to get rid of nitrogenous waste. So, of course, a byproduct of amino acid catabolism is urea. Another thing that I may have mentioned a million times in the past few weeks when I had my gout, uric acid, right? And when you get older, you're not as efficient getting rid of uric acid, and it causes a whole bunch of crystallization in your joints, and then you get a very painful condition called gout. So these are the two things, beautiful, both A and B. These are nitrogenous wastes, urea and uric acid. Uric acid is from nucleic acid metabolism, and urea is from protein metabolism. Protein catabolism or breakdown. Okay. Urine composition. Urine is mostly water, urea, uric acid, and also creatinine. Creatinine is the substance that we measure, and also inulin is another substance, another test that's for your GFR. And there should be, there shouldn't be anything like you need, like proteins you need. You shouldn't see that in urine. Blood you need. You shouldn't see that in urine. Sugar you need. You shouldn't see that in urine. What should you only see? Waste products and a whole ton of water. Okay. Urine volume is anywhere from 1/2 liter to 2.5 a day, right? And these you kind of have to know, not really for the exam, but for future reference for when you do practice. Usually around 50, 60 cc's or ml. Cubic centimeters and milliliters are the same thing. So 50 to 60 cc's per hour is normal. And when you have no urine volume, that's called anuria. That's bad. That means you're having kidney failure. Oliguria is also bad. Oliguria is when you start dropping, like, let's say it starts going 50 an hour, like 8 a.m. this morning. And then, or 50 cc's, and then it drops to 30, then it drops to 20, then it drops to 15. That's called oliguria. That means it's pending. And of course, the exact opposite, if you pee too much, that's called polyuria. Next, renal clearance, inulin and creatinine tests. Remember, these are both filtered by the glomerulus, but they're not really absorbed. Therefore, they're wonderful tests for GFR, and that's important. Storage and eliminator of urine, of course, all of these things here, minor calyces, major calyx, renal pelvis, it's just what? These are funnels in the medullary area of your kidney, or the middle area of your kidney, that helps you move the urine through the hilum and into your ureter. From the ureter goes to temporary storage, your urinary bladder, and then out the urinary bladder through your urethra. Now, your urinary bladder, of course, you can see it's even shaped like a funnel, and that's why they call it a trigon. Now, your urination is a reflex, right? So if this urinary bladder, which is only temporary storage, right? When it starts squeezing, it's going to start sending signals to your urethral sphincter. You have an internal and an external one. The internal, of course, you have no control over, and the internal, internal one, no control. External urethral sphincter, you can hold it for only so long, and for the same reasons that we talked about in the gastrointestinal tract as well, right? And there are smooth muscle fibers and muscular coat, which covers the entire urinary bladder, and that's called your detrusor muscle. Now, the differences between the female urethra and the male urethra. The male urethra is much longer and encased in the male penis, while the female urethra is much shorter. The labia minora and majora only provide some protection, and the close proximity to the female anus right here also complicates things for urinary tract infections here for my female patient versus my male patient. But know and understand that female patients are symptomatic, but most male patients are not. So increased chance of UTI due to the short urethra and close proximity to the female anus here. And it's not necessarily dependent on hygiene. Of course, prostate gland is a male and also could complicate matters if there's prostatitis or prostatic CA or prostatic carcinoma. You can see how it's going to squeeze on this area right here. I'm going to talk more about in the lectures to come what's the function of your prostate. Your urethra has a muscular coat, has a smooth muscle, which of course involuntary. External urethra is somatic nervous system control, and that's skeletal. Female versus male, we already talked about that. Micturition is another word for urination, and we already talked about that it is a reflex. So when the urinary bladder starts opening up, it's going to open up automatically the internal urethral sphincter. When you get old enough to control your external urethral sphincter, that's when you can hold it in. Right? And the micturition reflex center is the interneuron for that reflex is located in your sacrospinal cord, typically sacral 2, sacral 3, sacral 4 nerves. Okay. And And that's it for this chapter. All right. Good night for paying attention, and I'll see you in class.